the next one we're going to be talking about is bipolar. So bipolar the cause is just genetic. So just remember that. It's associated with depression mixed with hypermania. All right. So some assessments we're going to be doing for this we're going to be looking at is we want to see the mood, the behavior, the thought process of the patient, speech patterns, cognitive function. You want to monitor for all of that because that has to do with bipolar. And also make sure, are they dangerous to self or are they dangerous to others? The diagnostics that we're going to be looking at is the sad person rating scale and the young mania rating scale. That's the diagnostics we're going to be using for scales to see as severe. And remember, each person's their individual, so it just depends. There's bipolar 1 and bipolar 2. So I'm going to say the criteria. Mania for bipolar 1 is for at least a week, periods of depression, remission, may have psychosis, inflated self-importance when manic, distractibility with racing thoughts, and flight of ideas, pressured speech, engaged in dangerous activities, financial, sexual, decreased sleep, appetite, and purposelessness. So they're just all over the place, if that makes sense. Okay, so bipolar 2 is a little bit the same concept, except a little bit less severe. So they experience hypomania, so like lower mania, which is what makes it classified differently. Low-level mania, excessively active, no psychosis, rare needs to be hospitalized. Depression follows an increased risk of suicide still, but must have at least 3 symptoms for 4 days, and often still functions in society and work. So whenever it's DSM-5, it's like always says three, so it has to have 3 of the symptoms. This one didn't state. Okay. So these are the criteria for it. I'm going to talk about mania, and then I'm going to talk about depression symptoms because they're a little bit different. And depending on bipolar, just think bipolar 2, hypomania, the same thing except a little bit less. Like you may not claim those associations, stuff like that. So they're unusually, actually the first one I want to talk about is dangerous activities such as indiscriminate spending, reckless sexual encounters, and risky investment. So think about like even your money, you can like literally bank your family and just be like, oh, I decided to go on a shopping spree, no problem. And then you're like, I have no money left. So same concept. Okay. They could be unusually obsessed with and over-focused on their goals, grandiosity, extreme drive and energy, like, whew, you know, like you see very strong energy. Playing association would be like rhyming. I went to the park and then I went to FARC and then and they think they're funny. So that's the point. Flight of ideas, just like crazy level of just a flight of ideas, just drastically reduced sleep requirements, excessive talking, pressured speech, personal feelings, racing thoughts, just they think really fast, distraction by the environment, environmental events, purposeless arousal and movement. And this, by the way, is a nonstop physical activity, and the lack of sleep and food can lead to physical exhaustion and even death if not treated, and therefore it constitutes as an emergency, which really is important to know. Now the depression symptoms on the flip side are like the exact opposite. They may overeat or undereat, suicide risk, make sure to monitor for that, hypersomnia, really sleepy, psychosis may occur, and feelings of worthiness. So that's what you're going to see. So it's pretty simple and straightforward. Interventions are going to be, let me think, hold on. Psychotherapy, you're going to do ECTs, electronic convulsive therapy, has been to substitute the severe manic behavior. All right, so mania has, you want to give them finger foods because they're going, their mania foods are like carrot sticks or just like on-the-go foods, just because they forget to eat. Like, I just realized I forgot to eat. Okay, well, that was funny. Maybe I am bipolar, I don't know. Nursing students just diagnose themselves, but they're not allowed to do that because only a doctor can do that. Simple statements and instructions because they can't focus. So that's really, really important to make clear, direct. I also forgot to say that mania is associated with split staffing, so it's really important to monitor for that. Seclusion therapy may be needed. So just in case this happens and they're like really manic, the doctor order needs to be written every 24 hours. Emergency nurse put in seclusion needs to be obtained. Physician's order is within 15 and 30 minutes. So if the nurse is like, I cannot deal with this person, they just like stuff them in a closet. Okay, no, that's not how that does it, but they have a seclusion closet. They need to get that order within 15 to 30 minutes from the doctor in order to keep them there. But they are allowed to do it before they get the doctor's order if they're in real danger. Okay, so those were the interventions. Now we're going to talk about the medications associated with bipolar disorder. All right, so lithium is the main thing to monitor for. Lithium, the correct dosing is between 0.6 and 1.2 milliequivalents per liter. Let me say it one more time, 0.6 to 1.2 milliequivalents per liter. All right, so you have to stay within the therapeutic dose, or else it's, I guess, basically poison. You have to take it with meals. It helps alleviate the stomach. I'm gonna say a little bit on that. Start low and go slow. Check the thyroid and kidney periodically. And this is actually really important because it's contraindicated for cardiovascular disease, brain injury, renal disease, thyroid myasthenia gravis, pregnancy of breastfeeding under 10 years of age. So this is like really important. So thyroid and kidneys, check them periodically. So cardiovascular disease, brain, renal, thyroid, myasthenia gravis, and pregnancy or breastfeeding under 10 years of age. All right, so stop immediately if there's excessive diarrhea, vomiting, or sweating. The reason is because if it acts as it kind of acts like a sodium, so it's hard to explain. So let me see what the notes say. Dehydration can raise lithium levels to toxic. That's right, because it acts like sodium. So dehydration can rise. It's really important, and that's why you want to make sure the patient has at least 8 to 10 glasses of water when they're taking lithium. 8 to 10 glasses, it will decrease the sodium reabsorption if they have water. Acts like sodium, so do not take the water pill. Just thinking about that. Okay, so do not take the water pill. Take with meals, check the thyroid and kidneys. Okay, so toxicity is really important. So if they're experiencing nausea and vomiting, diarrhea, thirst, polyuria, slurred speech, muscle weakness, coarse, and tremor, this is a sign of toxicity of lithium. Monitor for that and stop immediately if that happens. All right, so then I want to talk about the other, because lithium is the most common. Anticonvulsants, valproate, carbamazepine are anticonvulsants, but that sometimes are used in bipolar. The main thing to know is if they use this, liver and platelet needs to be monitored with these anticonvulsants. There's an anticonvulsant called lamotrigine, and the main thing that I need to know is like start slow. There's a life-threatening rash. So fever, sore throat, swelling in the face or tongue, burning in the eyes, pain followed by red and purple skin rashes that spread, especially in the face or the upper body, causing blistering and peeling. So it's like a life-threatening rash. So fever, sore throat, swelling in the face, tongue, burning in the eyes, skin pain followed by red or purple skin rash that spreads, especially in the face or upper body, causing blistering and peeling. So kind of similar to that Ray's syndrome. There's sometimes bipolar, they take anti-anxiety meds, just know lorazepam, chlorrazepam. It's a GABA inhibitor. It must be tapered long-term. Use may cause cause dependence, withdrawal, tremor, anxiety, difficult concentrating, sensory disturbances. Antidepressants may trigger the manic episode. So antidepressants are really not advised for bipolar. Antipsychotics may be used if they're having psychotic symptoms. It's used in acute episodes. Slow speech, inhibit aggression. So if they're aggressive, they may be taking like risperidone or olanzapine to be aware of. Complications would associated with bipolar is suicide risk. You want to maintain the environment to be safe. Don't have like dangerous weapons around. Like anything could be considered a weapon, but be like ask if they have a suicide plan, and that will help you know how you keep that patient safe. Staff splitting is very common with bipolar patients. They can be very manipulative and demanding. Consistency among staff is imperative. If they limit the setting to be carried out effectively, so they have to limit the setting of not have too many patients. They have to make sure that they try to keep the staff most consistent as possible. So that's everything with bipolar. Study those medications and focus on that. And that's everything. So happy studying, guys. Bye.